Welcome to MedSurg 2 and your fluid and electrolyte unit. This unit, alongside of IV therapy, will comprise most, not all, but most of the information that will be covered on your IV therapy exam. That exam is actually pass-fail, and it is not factored into your MedSurg 2 course grade. However, fluid and electrolytes is a standalone unit. It is a graded unit, and it will be factored into your grade for MedSurg 2. This unit moves pretty quickly. We will have the entire unit and the exam all within the first week. That's so that we can set up to get IV therapy done. We have to get that done before we send you to clinical. So this is kind of how we're moving this along pretty quickly. I do intend to plan a review session before your exam opens, so keep your eye out for that. So I first want to just discuss homeostasis. And, at the end of Nursing 120, we did a real short unit on homeostasis. And homeostasis was reminding you that the body has an ability to attain and maintain an internal balance. And we have to have that ability. That's a vital function of the body. One of the ways that we do that is by utilizing the fluids within our body, and then of course the electrolytes that are dissolved in those fluids. But first and foremost, we have to talk about fluid. 50 to 60% of the human body is comprised of water. Now we're talking about the adult human body, because when you're first born, you're talking between 70 and 80%. Now that doesn't mean, they're sloshy. It just means that that person has a lot more body water. And as they age, if you just look at my little table there, as a person ages, you will see that their body water goes down. Well, the less body water you have, the better chance you have to be dehydrated in future. The other thing that you should be able to see there is a gender divide, where males have more fluid than females. And that's a simple fact that fat and fluid do not occupy the same space. Women have more adipose tissue, and as unfair as it is the truth. And so women have more adipose, so women have less water. Lean muscle mass has more water, so that's why males have more water than females do. So in order to achieve that homeostasis that I'm talking about, the body has to be able to regulate fluids. And we have several processes that the body uses to regulate fluids. We are going to discuss those. But the other part of homeostasis is using that fluid, that necessary fluid, to deliver nutrients to your cells, nutrients like oxygen, glucose, into the cell, and then in the process of metabolizing the nutrients, the cell makes waste products, nitrogenous waste and CO2, and those then must travel by way of fluid back into the vascular system so that they can be excreted eventually by the kidney. And actually, if you want to get real technical, it's not just the kidneys that excrete. Remember, the skin, our lungs, we're all part of that excretion, but the kidney does do most of it. So just to clarify. Now, when the process of homeostasis fails, then imbalances happen. And one of the most difficult things that we have to do in our assessment is figure out kind of which came first, the imbalance or the illness. Because we can have a situation where an imbalance actually leads to an illness, or an illness actually ended up causing a particular imbalance, or maybe the treatment for that illness caused the imbalance. Why is it important to figure out which came first? Well, if we treat symptoms, then that's called palliation. When we just treat symptoms, the patient may feel better, but we're not fixing the problem per se. But if we actually figure out which came first, which is the etiology of the problem, if we can figure out the cause or the etiology of our issue, then if we treat that, that's what's going to give us a good outcome that potentially leads to a cure. So it is important to try to figure out when there is an imbalance, is the imbalance independent and it caused maybe an illness, or was an illness responsible for the imbalance that we're seeing in our patient? Back in homeostasis, I did discuss the different fluid compartments with you, so we are going to go back over those real quick, but we're also going to make sure that we really understand what they are and the differences. So basically, our fluid compartments are divided into two large groups, intracellular and extracellular. Well, here's the thing about intracellular. Intracellular is all by itself. You're either inside the cell or outside the cell. So if you're inside the cell, you're intracellular. If you're outside the cell, you can be a lot of different things, but intracellular fluid is always the fluid inside of the cell. It comprises 40% of your total body weight. So 40% of the weight that you see when you step on the scale, that's your intracellular fluid, and it's actually the largest space. Even though we have to take all those little tiny cells, the fluid, all of those, and add it all together, when you add that all together, that is your largest space. So we call it our first space. First space because it's not difficult to access at all, but it's also very much larger than the other spaces. Well, it stands to reason that if you're not inside of the cell, you're outside of the cell. Intracellular fluid is intra, inside, within, however you want to say it. Extra is outside. But the thing is, there's a lot of different places that extracellular fluid can be found. The three that we primarily worry about, and really there's only two of these three that we worry about on a daily basis, is intravascular, interstitial, and transcellular. Well, intravascular is that which is found inside your vascular system, aka blood, but it's the liquid part of the blood, not the formed elements like the red blood cells. So we're talking about the plasma or the serum within your blood. That is your intravascular fluid. Now I'm going to talk interstitial before I talk why they're second and third. Interstitial is the space between your cells, okay? So this would be the tissue fluid as it's leaving the capillary and going out to bathe the cells. This is the fluid between those cells, all right? It's also where your lymphatic system picks up, lymph fluid and whatnot, but that's your interstitial space. Now, in the most technical sense, the larger of the two spaces is really interstitial. Intravascular is actually a little smaller. So, based on my previous theory of, well, the largest space gets to be first space, wouldn't the second largest space get to be second space? Oh, nay, nay. And that is because interstitial, even though it's the next largest space, it's really difficult to access. It's difficult to move fluid between the interstitial and the intravascular space, or even in the intracellular space. So since it's so difficult to get to, it's the third space. The second space is intravascular. Although it's slightly smaller than the interstitial space, it is much easier to access, much easier to get fluid in and out of. So, because of those criteria, intracellular fluid inside the cell, that's first space. Intravascular blood, that's second space. Interstitial fluid between your cells, that's third space. So, what about fourth space? Well, here's what I need you to know about fourth space. It's called transcellular. It's comprised of pretty much anything I haven't talked about yet. So digestive secretion, sweat, cerebrospinal fluid, synovial fluid, vitreous humor, aqueous humor, blah, 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 blah. If you've got fluid in a weird spot in your body, it's going to fall into this transcellular category. It's the fourth space, but it's also pretty irrelevant where fluid and electrolyte balance is concerned. It's not a major player. So other than to know that it exists, what its proper name, and what generally makes it up, that's about all we're going to ever talk about with transcellular. It just isn't part of the conversation when we're talking about fluid balance. So you already know right now everything you need to know about transcellular spaces. We would not have spaces if we didn't have a way to contain these spaces. So these fluid compartments are separated by membranes. These membranes have a special quality in that they are selectively permeable, meaning some things pass easily through the membrane and others do not. Sometimes it's just all about size. Small electrolytes, small ions, even non-electrolytes, water, all of those things pass through very easily, and partially because they are small. But larger solutes can still pass, but some membranes will let them pass a little easier than others. However, there are some where they won't pass without help. And we're going to talk about all of the different transport processes, like we talked diffusion and osmosis. We've also talked a little bit of active transport, not a whole lot, but we also talked a lot of filtration when we did renal, because what is the nephron but the glomerulus and the Bowman's capsule is sort of like a filter, and that is an ultrafiltration process. But what we're talking about here is the smaller solutes and water can usually move across the membrane, but something larger. Now glucose, does glucose easily go into a cell? No, it doesn't. In fact, if you actually want to get glucose into a cell, you're going to need help. That help is insulin. Insulin will position itself on a receptor on that membrane, and when insulin is in place, it's almost like it's a key in the lock, and when the key goes in the lock, the door opens wider, and then it allows that glucose to go in. But then once the insulin leaves the cell membrane, the key's no longer in the lock, so additional glucose can't go in there. So you keep needing more and more insulin to get more and more sugar inside the cell. And that's a very good example of active transport. Another example of active transport is when it's going against a concentration gradient. And I'm not going to go back through, I just don't have the time, but if you recall the sodium-potassium pump that you learned about when you did anatomy and phys, and you learned about that in the heart especially, that sodium-potassium pump is basically going against a concentration gradient, which is why it needs the pump to begin with, and that's what requires that active transport. So small molecules, small ions, water, they all move pretty freely, and they're just subject to the normal forces of diffusion and osmosis, which we'll talk about momentarily. But larger things like glucose require some assistance, and that assistance requires energy. That's called active transport. So let's talk about water. Water is the universal solvent or dissolving medium within the body. Here's the thing. Most of the time, we even find a way for fats to be dissolved in water at some point. Now, how the heck do we do that? Well, if you recall, there's things called phospholipids. They are water soluble on one end and fat soluble on the other end. So the fat soluble side goes against the fat because like goes against like. But when it does that, the water soluble portion is on the outside, and then it makes the entire thing water soluble. So point just being, you don't have to memorize all that or really remember it that well, but it is universal. Okay, this is what we use in our body as a dissolving medium. It makes up the largest portion of our body weight because 40% of our body weight is from the fluid from one compartment. We have, 4 technically, but 3 major compartments, so one compartment. And if you go back to that first slide, more than 50% of our body weight is body water. All right. Now, the percentage of your body water is affected by age. We saw that on that very first slide, right? Because the younger you were, the higher body percentage you had, body water percentage, but the older you got, the more it went down. It's also affected by gender. We saw that gender divide. And then it's also affected by body fat. So if you take any of those people in that little first slide that I showed you, but you add obesity to the mix, then you're going to drop that water level a few more percent, okay? Females, we discussed, have lower percentages of body water because they have higher percentages of fat. Males have higher percentages of body water because they have more lean muscle, and lean muscle is associated with water. I got a quick analogy for you. You ever bought a nice lean steak and then put it on the grill, and that steak, being lean, had water in it? But the minute you put it on the grill and you get the temperature up high enough, the grill causes the water to evaporate out of the meat. And while you've got a nice healthy steak, it might be somewhat a little tough to chew because all of the things that lubricated that muscle have evaporated away. However, if you go and get yourself a nice ribeye, and that ribeye's got all that marbling and all that fat through it, when you heat that thing up, it's not, the water goes away, sure, but the fat is it doesn't evaporate away, it just liquefies, and then it goes all over that steak. Am I making anybody else hungry? I'm making myself hungry. But anyway, it goes all over that steak, and then that's why that ribeye tastes so much better than that super, super lean steak. So maybe the steak will help you remember who has more water and who has, why the water evaporates away. Lean muscle has water. Fat has fat and less water. On that same vein, then, obese persons have less body water than the average person does. And one of the things that you have to recall, that we're going to talk a lot about water moving things around and being, a transport medium and all of this kind of stuff. But remember, it's our primary way to cool ourselves. Our bodies work by metabolizing, and in that process of metabolism, it creates body heat. Well, when we have more heat than we need, we have to have a way for that heat to escape away from the body. Our method for that is evaporation or sweat. But if you don't have enough body water, you won't make enough sweat, therefore you'll retain heat. So sometimes when a patient has a temperature, we have to figure out, do they have a temperature because they were dehydrated and that dehydration caused them to elevate their temperature? Or do they have some kind of infection that's causing them to have a temperature, and then the process of trying to cool themselves, that caused their dehydration? You see the fun? This is what, our job is going to be, is to solve this mystery. So let's talk about intaking water. Normal sources of intake for water, well, free fluids. I'm betting chances are somewhere within arm's reach of you right now as you listen to this lecture, you've got some free fluids, something to drink. We generally like to have fluids, and we generally sip on fluids most of the time throughout the day. But we also get water from some of the foods that we eat. Fruits and vegetables and, lean meats, they do have water. Now, of course, sometimes when you cook that lean meat, sometimes the water leaves. And then, but your fruits and vegetables, they tend to contain far more water. So if your patient is eating a lot of fruits and vegetables, but they're on a fluid restriction, and you're having trouble managing their fluid restriction, you might look at the number of fruits and vegetables that they're eating. Conversely, if your patient is, having trouble with dehydration and what they're eating is, very few fruits and vegetables, you might want to encourage additional intake of those to help with their sources of intake for water. And then last but not least, you've got the water produced by metabolic activity, most especially when you think about glucose metabolism. I know this is hard, and I know it hurts, but if you think back to anatomy and phys, you learned about glycolysis that takes place in the cytoplasm of the cell, and that turns glucose into 2-pyruvic acid or pyruvates. Those pyruvates then enter the mitochondria of the cell, and they go through the TCA cycle or the Krebs cycle, whatever one you like to say it. And once they go through that cycle, in the process of metabolizing that sugar, they actually make CO2 and they make water, all right? So metabolic processes actually create water, especially if they're metabolizing sugar. Now, what are some normal sources of loss for water? Well, lungs. If you have a job like mine, where your job involves a lot of talking, on days when I do lectures, or the good old days when we could stand in a classroom and lecture, having to project my voice and doing all the talking, mouth would get dry, everything would be dry, and in the process of trying to project my voice, I'm losing some fluid. And if you don't think that there's fluid in your breath, all you have to do is kind of breathe on your glasses or against a window. It's the condensation that's forming on that window, and it's the condensation that gets on your glasses that allows you to usually wipe them clean. So that proves to you that every exhalation that you have has moisture and droplets. And of course, in the world of COVID and the pandemic, this is why places oftentimes require a mask for certain close-up activities, because even just talking will cause some of that fluid and potentially some droplets to come out of the patient. So lungs are a big source of fluid loss. Skin by way of sweat. GI tract. You want the GI tract to be at least a minor source of loss, because if you don't have enough water in your stool, then it's like, concrete poop, and who wants that? Kidneys, well, that one's pretty obvious. We all urinate, and that is a loss of water. Metabolism also, though. Some types of metabolism actually use some water. So a lot of times the metabolism thing ends up balancing itself out. Just depends on the different types of food that you're eating. But always remember what we learned in fundamentals: 1 liter of body water, that is equivalent to a kilogram, and a kilogram is equivalent to 2 pounds. So 2.2. So if your patient loses roughly 2 or slightly over 2 pounds, and they lost it over a period of 24 hours, I'm sorry, they did not lose fat equaling 2.2 pounds in that 24 hours. What they lost was about a liter of fluid. And so they're probably down, they're probably having a deficit. Or if they were overhydrated to begin with, then they've brought themselves 1 liter closer to balance if they've dropped 2.2 pounds in the last 24 hours. So it's the body's job to strive for equilibrium between intake and excretion. Now, it's really hard to measure that. You're never going to be able to get perfect measure when you do I&O. Here's the thing. We do daily weights to get a much more accurate picture of somebody's intake and output, and basically it's like the results. But who wants to wait 24 hours to see if what you're doing is working? I promise you doctors don't. So we do intake and output, or I&O, so we get that up to the minute, idea of what's going on with the patient. But you always just have to almost mentally add about 500 cc's onto their excretion for the non-measurables, the insensible losses, the things that you have no, ability to measure normally. And if they're within about 500 cc's, like intake's about 500 cc's greater than output, then you are probably in balance for that day. Well, we've talked about water, which things are dissolved in. Now we've got to talk about what is dissolved in it. And those are the solutes. And primarily during this unit, we're going to focus our energies on electrolytes and non-electrolytes. Electrolytes are substances that loosen their physical bonds and become polarized, which what this just basically means is when they're tightly bound together, like in a grain of salt, they're so tightly bound together that the positive and the negative part of it are so close together that they truly neutralize one another. So there is no charge coming off of it because they have neutralized. But the minute you loosen those bonds and you start to pull them apart a little bit, then you've got one end that kind of takes on a positive and the other end that takes on a negative. And I tried to put a little picture down there so you could kind of see how that works, okay? So obviously the sodium is putting off kind of a positive charge and the chloride kind of a negative charge because they're a little bit looser as they're dissolved in water. Well, what that actually does is it makes the water rearrange itself so that on the chloride side, since chloride is negative, water will spin itself around so the positive part is closest to that negative because opposites attract, okay? Then on the sodium side, since sodium is positive, you can see that the water molecule has oriented itself so that the negative side, the oxygen side, is closest to the sodium. So this is kind of how it all works chemically. And of course, there's a physical change. When salt is in a grain, its physical structure is something that can be obviously felt. But when you dissolve it in water, you can't see it anymore, you can't feel it, but you sure can taste it. So you know it's there. But that dissolving process changes its physical form, okay? Now, we do need to understand that cations are all positively charged ions. So remember there's a T in cat ion, and that kind of looks like a plus sign. Maybe that helps you remember it. And then anions are negatively charged ions. So sodium is a cation, chloride is an anion. During this unit, we are going to talk about 4 major cations. We're going to talk sodium, we're going to talk potassium, calcium, and magnesium. Sodium is the primary cation in extracellular fluid, and it's most abundant in all body fluids together, okay? But it's the primary cation in extracellular fluid. Now here's the thing about extracellular fluid. Technically, when you're talking extracellular, you are talking intravascular, interstitial, transcellular. But when somebody is just talking about extracellular fluid in general, most of the time it's implied that they mean the vasculature because it's the second space. Third and fourth, don't play into that as much. So if you see something about extracellular fluid volume, it's probably focusing on intravascular, okay? Potassium is the primary cation and most abundant in intracellular fluid. So sodium is to the blood and serum what potassium is to inside the cell. Okay, they are the primaries, but they're the primary in each of their own locations. Then you've got calcium. Calcium is required for neuromuscular activity, or I should say appropriate neuromuscular activity, coordinated neuromuscular activity. It's also required for enzyme formation, and the one everybody always forgets is blood coagulation. Okay, you just had hematology not long ago, and in heme you learned that there were 2 different places in the clotting cascade where calcium was a necessary component. So when patients have calcium deficiencies, yes, we look at, blood or their bone, and we look at some of their neuromuscular stuff because we're going to talk about twitch, CCs, all that good stuff. But you also will see an increase in bruising because they don't coagulate blood as easily. And then we have our magnesium. Magnesium is a trace element in extracellular fluid, but it's the second most abundant in intracellular. So whereas for extracellular in the blood, magnesium is barely measurable. I mean, it's tiny amounts. But in the cell, right behind potassium, it's the most abundant. So it plays a much bigger role in intracellular fluid than extra. And then, of course, we've got our major anions. Now, you got chloride, bicarb, and phosphate. Chloride and bicarb, I don't go into too much. You're going to hear plenty about bicarb, with acid-base balance, and you already have because you've done that in respiratory. But I do talk about phosphate just for the same reason I discussed it in renal, because calcium and phosphate have a reciprocal relationship. We will talk about phosphate. It's, in fact, probably about the only anion we're really going to discuss in fluid and electrolyte balance. Just some general properties of electrolytes are the fact that they have to maintain a balance of positively and negatively charged ions. But that doesn't mean necessarily 1-to-1, okay? We're going to talk about that in a sec. But the concentration of electrolytes in a solution is measured in milliequivalents. And here's why that's important. If you're trying to measure something, if you're trying to measure apples and oranges, you can count them, but they're not the same. They're not the same thing. So the beauty is if something is measured in milliequivalents, and milliequivalent is the chemical combining power of an ion, its ability to combine with other ions, okay? If it's measured in milliequivalents and you've got two different things that are measured in, so if all of a sudden instead of apples and oranges, we're just calling it fruit, suddenly you have this ability to make it make sense to measure one against the other. So what does this mean? Well, we talked about this briefly in homeostasis, but if you've got a sodium ion is missing one electron, so it has one additional proton, and it has a +1 charge. Chloride has a bonus electron. It's got an extra, just walking around just, with a little extra in its pocket, and so it's got a -1 charge. So they go very well together because sodium needs the extra electron to make itself balanced. Chloride needs to get rid of the extra electron to make itself balanced. But now let's flip this around. What if we're talking about calcium? Calcium is missing 2 electrons. It's got a +2 charge. So you can still put calcium with chloride, but because of its chemical combining power, it's going to require 2 chloride. So whereas sodium chloride is 1-to-1, that's how we maintain the balance of positive and negative ions, calcium, being a +2, is going to require 2 chlorides in order for it to be in balance. Hopefully that makes sense to you. Electrolytes move freely from one compartment to another, but a lot of times they are concentrated in one compartment. So the example being sodium primarily concentrated in extracellular fluid or intravascular, potassium primarily concentrated in intracellular. But we know we have some potassium in the extracellular fluid because that's how we get potassium levels. Remember, when we draw blood on people, we're getting serum levels. That is a measure of what's in the second space, all right? So we know that there's some mixing. It's just that there's an abundance of a particular cation depending upon which compartment that we're talking about. So the functions of electrolytes are to maintain the volume, or help maintain the volume, of both intra and extracellular fluid. Sodium helps with extracellular, potassium helps with intracellular. To help maintain our acid-base balance, we've just mentioned bicarbonate. Bicarbonate is an anion. To maintain neuromuscular activity, calcium, and you're also going to find out magnesium plays a part in this as well, but calcium for sure has to be in balance to have normal neuromuscular activity, and then to also assist with the metabolic functions of the body. There are a lot of enzymes in metabolism that require a particular cation or anion. For instance, a lot of enzymes have magnesium in them, but you also in metabolism make something called ATP, adenosine triphosphate, and phosphate is an anion. So it plays a role in a lot of different places in the body. So let's talk functions of non-electrolytes. These are substances in the body that don't polarize. So even though they're dissolved in water, they don't polarize. They don't have a negative end and a positive end. And in these situations, they're still osmotically active a lot of times, especially the glucose and the protein, okay? But they don't polarize. So urea, protein, glucose, creatinine, and bilirubin all fall into this category. And because of the fact that they don't polarize, they do not have the qualities that cause them to be measured in milliequivalents, because milliequivalent is the chemical combining power of an ion. So these are going to be measured in milligrams per deciliter. Now, a little side note, in this region of the country, a couple of electrolytes are sometimes also measured in milligrams per deciliter. Not sodium and potassium, but we will talk about them. Different areas of the country will measure them, they'll use milliequivalents as the normals, whereas this area of the country tends to use milligrams per deciliter, and I will discuss that when we get to each one.